Good afternoon, everybody. It's a great honor for me to be invited here to meet with you. Today, I will talk about critical point in HPV surgery, especially critical point in surgery for high-cholangiocarcinoma. My talk includes 3 parts. First one is how to diagnose the resectability. And the second, how to manage the preoperative risk of the ectopic patient with high-cholangiocarcinoma. And lastly, I will talk about how to resect and for a very locally advanced high-cholangiocarcinoma which need combined vascular resection and reconstruction. Resectability of high-cholangiocarcinoma is decided according to the diagnosis of the morphological extension of tumor. Especially, we must be very careful to diagnose local extension of the tumor along, of course, along the biliary tract. But we must be careful to diagnose perivascular extension of the tumor. And the functional reserve of the future remnant liver is also very important to perform the safer hepatobiliary dissection of the ectopic patient. And finally, as you know, the lymph node metastasis is a very big prognostic factor of any type of cancer. In the last century, we used US, CT, and MRCP to diagnose the local extension of the main tumor. And after that, we used multiple PDBD or endoscopic biliary drainage, which was followed by angiography to diagnose the local anatomy of the vascular structure. And I am a very old surgeon, so most part of my talk today is actual cases of the last century. But in this century, we use US, MDCT, MRCP, and MDCT. And most of the diagnostic information could be obtained from this investigation. And after that, PDBD or ENBD was used to decompress the biliary structure. And recently, we prefer to use nasobiliary endoscopic nasobiliary drainage ENBD, and unilaterally or bilaterally. In 1980s, I have developed the intrahepatic segmental biliary anatomy of the liver according to the Quino's segmental anatomy of the liver. This is a modification of Quino's portal vein anatomy of the liver. This is very important and very useful to diagnose the preoperative biliary investigation, and also very helpful to design the surgical procedure preoperatively. How to diagnose the local extension of the main tumor? And we must pay attention to the local extension of the main tumor, and predominantly involve the segment, which side is predominantly involved. Of course, anatomical investigation of the intrahepatic sectional, subsegmental, and subsegmental bile duct is very important. And the resection line of the interhepatic segmental and or subsegmental bile duct is very important to make arterial resection. Of course, anatomical variation of biliovascular structure is also very important. In the 1980s, I have developed several types of hepatic segmentectomy with coded lobe resection for viral carcinoma of the hepatic iris. In the predominant left-sided cholangiocarcinoma, left-sided hepatectomy can be indicated. On the contrary, the majority of the right hepatic side of involved right-sided hepatectomy is indicated. In a special case of localized carcinoma at the hepatic iris, central hepatic segmentectomy with coded lobectomy is indicated. Anyway, the coded lobe resection is very important to establish R0 resection. As coded lobe branches are joined at the hepatic conference, therefore, cancer will remain along the biliary ducts of the coded lobe if we use only viral resection and reconstruction without the hepatectomy. Therefore, coded lobe resection is mandatory in arterial resection of the higher cholangiocarcinoma. This is my policy. In the 1990s, we have developed further anatomical studies of the interhepatic subsegmental anatomy. This is a typical findings of standard drawing of the intrahepatic subsegmental bile duct anatomy. For example, in the segment A duct, 8A, 8B, and 8C, you see that 8A is a ventral branch, 8B is the lateral branch, and 8C is the dorsal branch. This type of findings is very important to diagnose and to resect and to reconstruct the interhepatic subsegmental bile duct. Now I'd like to speak about the proximal resection limit of intrahepatic segmental duct according to type of hepatectomy. In the case of right hepatectomy here, resection line of the left hepatic duct was here, above the confluence of segment 4 and 2+3 ducts here. In the case of right trisectionectomy, the resection line should be around the confluence of segment 2 and 3 ducts. On the other hand, in the left hepatectomy, right anterior and posterior segmental duct should be resected here at the confluence of the 8 and 5, and here the posterior duct on the cranial side of the right portal vein. In left hepatic trisectionectomy, right posterior sectional duct should be dissected here behind or cranial side of the right portal vein. Now I will show you an actual case of the right trisectionectomy and how to approach to the left lateral sectional duct here. As you know, Professor Bismuth classified the higher cholangiocarcinoma and type 1, 2, 3, and 4. He said his type 4 is unresectable, but actually I resected a considerable number of type 4 cholangiocarcinoma. Therefore, type 4 is resectable. Please believe me. Here you see a very, very advanced hydrogonadal carcinoma. This case was experienced in 1993, 27 years ago. Here you see intrahepatic bile duct was separated into multiple units. Right and left hepatic duct is separated, and the segment of the duct is separated. And here you see the confluence of 2 and 3. However, when we take selective conjugography of the left lateral sectional duct here, cancer progress is defined proximally to the confluence of segment 2 and 3 ducts. Therefore, from these findings, I decided to perform the right trisectionectomy after right portal vein, after right tris segmental portal vein embolization. And the resection line is scheduled here on the left lateral side of the fascial ligament, and to resect the segment 2 and 3 duct here, proximally to the junction of 2 and 3. How to approach to the umbilical plate or the umbilical fissure in the case of right trisectionectomy? Here you see Professor Quinault. I met him in 1991. Looking at his book, this is his first book written in the French language. He published this book 1957 when he was very young, before 40 years old. Very big book, French book. I learned this book and I found how to approach the umbilical fissure or umbilical plate. Here you see, he described here, how to approach to the umbilical plate here, behind the umbilical portion of the left polar vein. We should divide or open the umbilical recessus, right side of umbilical recessus, open the serosa, and divide the left medial branch, segment of branch, and go up behind the umbilical portion of the left polar vein. Then we can expose umbilical plate here, umbilical plate here. This is a very important technique to perform the anatomical right trisectionectomy. And I applied this technique, mobilizing the umbilical portion of the left portal vein from the right side, dividing the medial branch, many medial branches of the portal vein for the segment 4. And after mobilizing the umbilical portion of the portal vein, we can expose the left lateral sectional duct on the right of the mobilized umbilical portion of the left portal vein. So we can see the left hepatic artery on the right side of the mobilized umbilical portion of the left portal vein here. Usually, left hepatic artery runs into the liver from the left side of the umbilical portion. But after dividing the umbilical portion, we can expose the left hepatic artery on the right side. After that, liver transection is carried out on the left side of the fascial ligament. Actually, umbilical portion of the left portal vein was mobilized from the right to the left side. Here you see mobilized umbilical portion of the left portal vein. And we can expose, here you see hydra plate, which covers the lateral segmental ducts behind here, connective tissues. After dividing the umbilical portion, we can expose the left lateral branch of the portal vein and the hepatic artery. Actually, the exposed left lateral sectional duct here, segmental duct, B3 and B2 here, and the left hepatic artery was exposed on the right side of the portal vein. And the portal branch of segment 3 is here, and segment 2 is here. And the left lateral segment duct 3 and 2 could be divided here, proximally to the confluence of the B3 and 2. And after removing the liver, you can see the orifice of the segment 2 and 3 duct separately. And in this century, the diagnostic measure was different, improved. We can diagnose the main part of the tumor by MRCP, and we can decide resection side. In this case, resection side should be the right side. And here you see a main tumor, and diffuse cancer invasion was diagnosed here, and main tumor is here, and the anterior posterior duct separated. So right side is predominant. Therefore, PDBD was, the catheter was inserted from the 8, and the tip of the catheter was introduced from the 8 to the left. And here you see selective conjugography of the left hepatic duct. Clearly demonstrated here. You can decide a resection line here, proximally to the confluence of segment 4 and 2+3. Here you can see the syringe anomaly of the biliary duct of the segment 4, ventral branch, and dorsal branch of the segment 4 here. Actually, we could confirm the biliary anatomy of the resected margin of the left hepatic duct. And one more ventral branch of the segment 4 was clearly demonstrated here, and the other branches were included in here. Anyway, this type of anomaly we sometimes encounter. We must be very, very careful not to overlook the very, very tiny branch to prevent post-operative biliary complication. In this century, the preoperative management changed. Recently, we use US, MRCP, and MDCT, and most of the information can be obtained by 3 diagnostic procedures. After that, biliary drainage procedure can be decided. Recently, we prefer to use ELBD to prevent seeding metastasis along the PDBD sinus tract. And we have been discussing about ELBD procedure, which should be used, unilateral approach or bilateral approach. But recently, we have been concentrated to prefer to use unilateral ENBD for the future remnant liver. Actually, here you see, after diagnosing the main part of the tumor, approximately, mainly predominantly involved the right side. And here you see a left medial branch conference is involved here. From these findings, ENBD catheter was introduced up to the B2 and B3 separately. 2 ENBD catheter is introduced for preparation of right hepatic sectionectomy. But here, we must be very, very careful to investigate the possible existence of the anatomical variation of both biliary structure and vascular structure. Now I will show you a very strange anatomy. And anyway, we must be careful to diagnose sectional and segmental, subsegmental bile duct. And we must be careful not to overlook the unusual or strange biliary variation. We have published very strange anomaly or variations of biliary structure at the hepatic hilus. This is a very common or not so rare biliary variation of the infraportal right posterior sectional ducts. The frequency of this variation is less than 10%, not so rare. Anyway, infraportal variation of the right posterior sectional duct. This is a very, very rare anomaly of the segment 3 ducts, which runs ventrally to the umbilical portion of the portal vein. And this is the more strange and very rare anomaly of the infraportal left coded lobe branch B1L, which runs ventrally to the laterally and ventrally to the umbilical portion of the portal vein, and run here and join the left hepatic duct or the common hepatic duct in front of the portal vein. Coded lobe branches usually runs behind the portal bifurcation. Usually, here you see, coded lobe branch usually runs behind the portal bifurcation. But this anomaly shows that coded branch runs ventrally to the portal bifurcation. Now, I would like to show you how to deal with difficult biliary anatomy preoperatively and intraoperatively. And preoperatively, we must investigate how to drain the biliary duct and how to introduce a catheter to the appropriate position. And intraoperatively, we must be careful how to confirm the difficult anatomy and how to dissect and reconstruct biliary ducts for the future remnant review. Now I will show you the very rare anatomical variation of the interhepatic segment duct. Here you see diffuse cancer progress above and below the hepatic complex in the coronary view. Looking at the actual view, you see biliary duct, direct duct, B2, which joins the biliary duct of the left coded lobe branch. B2 joins the B1L here. It can be demonstrated here in the coronary view. B2 plus 1, this one, runs here below the umbilical portion of the left portal vein. This anatomy is quite rare. Usually B1 should be above the complex, above the umbilical portion. Therefore, this is very, very rare. So, preoperatively, we make a schedule how to drain this anomalous biliary ducts to confirm this anomaly intraoperatively. So we introduced a PDPD catheter through B8, and tip of the catheter was introduced into the B2, which has a congruence of the B1L. And here And the caster was passed across the main tumor here. And intraoperatively, we could confirm this anomalous branch here. This branch, including B2 plus B1L, this branch passed above the umbilical portion of the portal vein, passed caudally to the umbilical portion of the portal vein, and passed behind the hepatic artery and above the portal vein here. Very strange anomaly. After dividing the liver along the main portal fissure, we could confirm the anomalous local anatomy of the discipline, and the lateral section of ductus, rectal and medial left hepatic duct, main medial left hepatic duct 3+4, and 2 plus B1L here, which interrupt the left portal vein. Even after dividing the liver, we could not remove the liver because of the entrapment of the biliary duct. And even after dissection of the left hepatic duct here, we could not remove the liver because of the entrapment of the strange anomaly of the here. And here you see a prolonged left portal vein because of the anomaly. And after that, I decided to dissect and reconstruct the prolonged left portal vein to shorten the left portal vein. Prolonged left portal vein is a very dangerous anatomical situation, which developed post-operative portal thrombus because of a prolonged branch of the left portal vein. Therefore, I decided to dissect and reconstruct the left portal vein here to remove the liver and bile duct. Here you see combined portal vein dissection and reconstruction is carried out to remove the liver and right liver and the caudate wall and the biliary structure and the portal vein. This is a short summary of one part of my talk. Segmental, subsegmental anatomy of the intrahepatic bile duct should accurately be diagnosed preoperatively. It is very important to preoperatively and to design a radical operative procedure. And we always be careful to diagnose the anatomical variation of the component pattern of the segmental and subsegmental bile duct to avoid unexpected post-operative biliary complications. Next, I will show you anatomical variation of the very advanced case. This is a very rare anatomy of the replaced segmental branch of the right hepatic artery, replaced right posterior hepatic artery. Here you see a very advanced type 4 bismuth hierocardiocarcinoma. Here you see a big tumor at the hepatic iris, and the bilateral hepatic duct, intrahepatic duct is dilated. And here you see portal veins involved. And also right hepatic artery runs in the tumor. So both portal vein and hepatic artery is involved. And the choreography shows diffuse cancer invasion along the intrahepatic segmental duct. Most of the anterior sectional duct, segmental duct is involved. Subsegmental duct is also involved by diffuse cancer. Also, the right posterior segmental duct, subsegmental duct is also involved. Segment 6 duct is separated. Also, the segment 7 duct could not be demonstrated. Faintly witnessed here. Anyway, diffuse cancer invasion can be observed here. From these findings, How do you think about resectability? Maybe resectability is very, very low. Next, maybe for her, we propose just one. Here, PDP shows diffuse cancer invasion along the left polar vein. However, right is almost okay. And the next, then is left trisectionectomy indicated. We discussed about the resectability. Next, hepatic arteriography shows diffuse cancer invasion along the left hepatic artery and the right hepatic artery. Both right and left hepatic artery are diffusely involved. However, during angiography by ourselves, we could find replaced right posterior hepatic artery, which was not involved by local cancer extension. And the subsegmental branch of the segment 6 could be demonstrated. And here you see collateral circulation communicating sorry. Segment 6 hepatic artery communicate with segment 7. Segment 7 branch could be demonstrated from replaced segment 6 branch. From these findings, I decided to resect this case. It might be resectable. And I will show you how to approach this very, very advanced case through left hepatic trisectionectomy. In this case, key point is how to isolate and how to isolate the bile duct or the segments right posterior section, and how to isolate the left right posterior sectional branch of the polar vein, and how to approach to the bifurcation, the conference of the 6 and 7. Actually, left polar vein could be isolated and could be taped, and the segment 6 replaced artery could be isolated and taped. And left polar vein could be divided, and peripheral branch could be isolated and taped. And the left trisectionectomy could be performed. And the intrahepatic biliary duct was divided here, segment 7 and 6 BC, and the ventral branch of segment 6. Separately divided. Looking at the resected specimen, here you see dissected margin of 7 and 6, we could obtain considerable length of each segmental duct, 6 and 7. And here you see a diffuse cancer invasion around the segmental duct here. Next, I will talk about the lymph node metastasis. This is a very big prognostic factor of the hydropharyngeal. We already discussed how far should we dissect the lymph node in these many, many years. But I will show you my novel philosophy from our clinical experience. This is a very old paper. Lymph node metastasis from hydropharyngeal. We had a retrospective analysis of clinical cases. Here you see a survival curve here. Group A is negative lymph node metastasis. Group 2 is regional lymph node metastasis. Group 3 is a para-aortic lymph node metastasis. Positive and positive. There's a significant difference in each groups. Anyway, the positive para-aortic node metastasis is not so bad here. Looking at positive para-aortic node metastasis here, Group A is a microscopic metastasis, but macroscopic negative. Group B is both microscopic and macroscopic metastasis. There is a significant difference in survival between the macroscopic positive and negative metastasis. But looking at here, macroscopic positive para-aortic node case is same in survival with undissected patient. So if intraoperatively para-aortic node was negative, so we should go to resect the tumor. This is our first experience. Next one, we investigated the significance of the micrometastases. Here you see micrometastases. Here you see PN0. Group A is PN0. And group A is PN0 without micrometastases. Group B is PN0 with micrometastases. There was no significant difference between the two groups, PN0 with and without micrometastases. This is very important information. Group C is a regional and or para-aortic node metastasis. Therefore, we concluded that nodal micrometastasis has no survival impact in patients with otherwise lymph node negative hydropharyngeal carcinoma who underwent extended hepatectomy. Last one is a little bit different approach. Lymph node, here you see, lymph node metastasis is better classified based on not on location, not on number, and not on location, but on number. Positive number lymph node is very important. And we would advise we should assess the nodal status, histological examination of the 6 or more lymph node should be examined. Anyway, our HPV surgeons should keep in mind long-term survival is possible despite distant node metastases. So this is the summary of the second part of the lymph node metastasis here. Next, just one minute. Next, I'll talk about how to manage the preoperative risk of the patient with high-cholangiocarcinoma. We have developed several types of perioperative management procedure. Selective PDBD for segmental cholangitis, very important. And the portal vein embolization to increase the safety of major hepatectomy. And we used valve replacement during external beer drainage and symbiotics combined with early enteral nutrition. This type of perioperative management procedure was very, very useful for safer hepatobiliary resection for high-cholangiocarcinoma. This is a very old paper. This is a technique how to deal with preoperative segmental cholangitis. This is a super selective introduction of a catheter into the right caudate branch. This was the focus of the segmental cholangitis in the caudate row. And here you see a selective introduction of PDBD catheter into the segmental 4 branch. This is the focus of segmental cholangitis, together with liver abscess in segment 4. This type of infectious complication must be treated preoperatively. And as you know, the portal vein embolization is very, very important to increase the safety of major hepatectomy. About 10% of the volume moved from embolized area to the contralateral side in 2 weeks, about in 2 weeks, 10% move. And in the last century, I aggressively performed multiple PDBD and portal vein embolization before difficult hepatobiliary resection for high-cholangiocarcinoma. And in the last century, many centers in the world used preoperative PDBD, which was followed by portal vein embolization. This is the strategy in the last century. Gradually changed. In this century, as I told you before, US MRCP and MDCT have been used to diagnose the extension of the main tumor. And the resector procedure have already been confirmed by this preoperative diagnostic procedure. And the biliary drainage procedure is recently, ENBD is preferably used. And the unilateral for future remnant liver is a main strategy in most of the Japanese major centers. As I told you here, selective introduction of ENBD catheters in future remnant liver. However, we must be very careful. First step, we introduce ENBD catheter after LCP. Here you see in the case of left-sided hepatectomy, the ENBD catheter is firstly introduced into segment 6 duct, and the ENBD is established here. However, this patient developed cholangitis after segment 6 ENBD, and the cholangitis was developed in the left side. So catheterization into the page 6 and 7 was carried out. This is a bilateral ENBD here to treat the cholangitis preoperatively. We must be very, very careful. Always we must treat preoperative cholangitis. Next is, I will show you here. MDCT shows tumor here at the hepatic conus, separate the right and the left duct. Which side is predominantly involved? Bilirubin level is increased from here to here, even after ENBD. ENBD was introduced in the segment 3 duct. Here you see ENBD is introduced here in the segment 3. But serum bilirubin level increased after ENBD. Then PTBD was carried out here from the right. And here you see ENBD is in segment 3, PTBD in segment 8. However, the serum bilirubin level did not decline even after bilateral ENBD, bilateral biliary drainage. Then we removed the ENBD catheter, and the tip of the right PTBD catheter was introduced from the right side to the left side. The tip of the catheter was placed in the segment 3 duct, and the bilateral decompression could be obtained. And after that, here, serum bilirubin level gradually decreased here and here. It took 1 month from May 1st to May 30th. Bilirubin level gradually declined to around 3. Now, we are ready to perform hepatectomy. Which side should be resected? In this case, we perform left hepatectomy and the resection and reconstruction of the biliary duct at here, like the posterior and the anterior here. Because segment 4 duct and 2 and 3 duct is involved here. This is a very, very difficult case of chronic cholestasis because of delayed biliary decompression. Right anterior and posterior duct is separated. Also left is separated. Left lateral and left medial, 2 plus 3 and 4. Segment 4 duct is separated into multiple units. Well, from these findings, right trisectionectomy is indicated. However, the resection rate, volumetric study demonstrates resection rate is 80%. So we perform right trisegment portal vein embolization. However, bilirubin level still high because he had chronic cholestasis and he had ascites because of the chronic biliary cholestasis. And we, even after portal vein embolization, liver function of the future remnant liver was not good. Then we performed percutaneous transhepatic biliary ablation. Here you see volume of the right lobe gradually decreased. And this is the volume of the left medial segment. And this is the volume of left lateral section gradually up after both portal vein embolization and biliary. This is a portal vein embolization here. And here you see a biliary ablation of the posterior sectional duct. 8 times for right posterior sectional duct, and 3 times for right anterior sectional duct. Biliary ablation was effective to increase the volume of the left lateral section here, from here, and here finally, big left lateral section. And ICG-K value of the future remnant liver gradually increased. K value could not reach at 0.04, but we decided to perform right trisectionectomy. Surgery was successful. It was possible, like here. We recommend the ICG-K value of the future remnant liver should be above 0.05. But this is a very important case of the very risky extended hepatectomy, but successful. We have developed several preoperative measures to prevent post-operative or preoperative infectious complication. By replacement during external biliary drainage can restore the intestinal barrier function in patients with biliary obstruction, primarily due to repair of the physical damage of the intestinal mucosa. Therefore, we must introduce externally drained bile into the intestine from the nasogastric tube, or patient should drink by themselves. And here you see we used post-operative symbiotics, and here you see the infectious complication was actually reduced here. And average infectious complication reduced. And actually, post-operative hospital stay was reduced. And the average length of antibiotic treatment was reduced. Anyway, post-operative administration symbiotics combined with early enteral nutrition can reduce the post-operative infectious complication. Actually, we could reduce infectious complication. This is a randomized control trial. We used pre-operative and post-operative administration of symbiotics with enteral nutrition, and pre- and post-operative administration of symbiotics can evidently reduce the post-operative infection here. 3 papers we published in international journal, and actually here you see post-operative liver failure and the post-operative hospital days reduced after administration of symbiotics and bile replacement techniques. It was gradually decreased since 2001. And here you see, during the 2006 to 9, liver failure was 4.0, and the hospital days declined down to 1.1%. This is a very important message of perioperative measures. Next, final part. How to dissect the vascular structure and how to reconstruct the vascular structure. We usually diagnose main part of the biliary involvement. However, we must be very careful to investigate the possible vascular involvement and which side is involved. And the combined vascular dissection and reconstruction are possible or impossible. As you may know, the combined portal vein dissection in hepatobiliary dissection had been reported from Western country and Japan. First report from Western country here, Dr. Longmire from UCLA reported extended right hepatectomy with portal vein dissection and reconstruction. His first report was appeared in the Annals Surgery in 1973. In the first case of Japanese combined portal vein dissection and reconstruction in right hepatectomy was carried out in 1965. And the simultaneous dissection of hepatic artery and the portal vein was reported in 1983. We must learn from the past of the Japanese pioneer. Dr. Kajitani reported his first successful case of portal vein dissection in reconstruction in right hepatectomy in Japanese Journal of Shujutsu in 1966. And Professor Suzuki from Keio University reported simultaneous portal vein and hepatic artery dissection and reconstruction in left hepatectomy. First in Japanese Journal, and the second in Archive Surgery in 1986. Dr. Kajitani, my mentor, this is his original drawing of his operation record, written in 1965 at the Tokyo Cancer Institute Hospital. I learned him very much. He performed the right hepatectomy, and the portal vein was reconstructed. To anastomose the proximal end of the portal vein to the side wall of the inferior vena cava, establishing the egg fistula, and the hepaticogenoscopy was carried out. This patient could survive 3 years and 11 months and died of peritoneal metastasis. Autopsy clearly shows normal liver even after egg fistula. This is a report of the Professor Suzuki from Keio University. He succeeded to 2 cases of simultaneous resection of right hepatic artery and right portal vein. And for his hepatic artery reconstruction, he used here great saphenous vein graft. And here you see the end-to-end anastomosis between the right posterior branch and the right gastroepiploic artery. Anyway, 2 cases survived more than 1 year. This is a memorial report from Japan. Now I would like to talk about distal resection limit of the portal vein. In the right hepatectomy or right trisectionectomy, distal resection line can be here, oblique resection of umbilical portion and the segment 2 branch here. And in the left hepatectomy, here, and or here in left trisectionectomy, right posterior portal vein branch. And sometimes in this type of left hepatectomy, vein grafting may be necessary. And I will show you the actual case of the very, very advanced case, which was treated by very advanced surgical techniques. Here you see, CT shows a diffuse cancer invasion along the portal vein here at the hepatic iris and down to the conference near the splenic vein junction. And PD-PD choreography shows diffuse cancer invasion along the right segmental ducts, and here along the left lateral, left medial branch. But yeah, I thought this can be dissected by right hepatectomy here. PDP shows a diffuse cancer invasion above the bifurcation of right anterior and posterior. And here, left lateral extension of the tumor is close to the base of the umbilical portion of the portal vein here. And ultrasonography clearly demonstrates diffuse cancer involvement, periportal cancer invasion up to the confluence of segment 2 and the umbilical portion. This is a dissection limit of the left portal vein. I used oblique dissection and reconstruction at the base of the umbilical portion of the portal vein in right hepatopancreatic duodenectomy. Here, actually, umbilical portion could be taped, and left here, P2, lateral posterior branch could be taped, and the resection line was scheduled here. And after dividing the pancreas here, proximal extension of cancer along the portal vein was here, near the splenic vein junction here. So resection line could be designed here, just distal to the splenic vein junction here. So very long vein graft is necessary to reconstruct the portal vein here. After dividing the liver, here proximal portal vein reconstruction was carried out here. After placing the vascular clamp proximally to the splenic vein junction. And the vascular clamp was placed here obliquely on the umbilical portion of the portal vein and the P2 branch here. And the oblique dissection of the portal vein was carried out here after proximal portal vein reconstruction. This is the intraorbital view. This proximal taping here and distal taping here too, and the umbilical portion. After dividing the liver, proximal portal vein reconstruction was carried out between the main trunk and the external iliac vein graft. After that, left portal vein is resected here, oblique clamping here, UP and P2. And the portal vein was resected here, obliquely resected here. And this end of the iliac vein graft was here. And I incise the bilateral wall of the graft to to make a big lumen of the anastomosis, because I dissected the left polar vein here. Oblique resection make a big anastomotic site. Therefore, this is a special technique to incise the bilateral walls of the graft. And here, firstly, left side of the obliquely incised left polar vein is anastomosed by a running suture of 5-chlorine. And next, left side wall, right side wall is anastomosed. And the oblique anastomosis was completed. And here, the oblique anastomosis was completed. And here you see a reconstructed polar vein. The distal end of the anastomotic site is up to the umbilical portion of the polar vein. This surgery was carried out in 2000, 20 years ago. Professor Peter Neuhaus from Berlin. Incidentally, he stayed in Nagoya and he helped me to perform this surgery and write the HPD with polar vein dissection and reconstruction using right external vein grafting. This patient survived 2 years and 2 years and 5 months. This patient could discharge the hospital in the post-operative week without any complication. Now I will show you another case of both simultaneous resection of the polar vein and the hepatic artery. In the last century, I used subvenous vein grafting for hepatic arterial reconstruction. But in this century, we asked plastic surgeon to perform the microsurgical techniques to reconstruct hepatic artery. This is a very advanced case. The right hepatic duct is separated into multiple units. Left is also separated into multiple units. And preoperatively, this is a very old case. So we could not have 3D angiography. So after taking arteriography and photography, we designed, we drew the extension of the tumor, and we designed how to dissect and reconstruct the polar vein and the hepatic artery. Diffuse cancer invasion was demonstrated along the polar vein and the hepatic artery. And the hepatic artery section line was scheduled at proximally to the confluence of bifurcation of the anterior and posterior branch. And here you see the proximal resection line was designed as a proper hepatic artery. Actually, the distal and the proximal site of the both polar vein and the hepatic artery could be taped and reconstructed. A great subvenous vein was used for hepatic arterial reconstruction, and the right external iliac vein was used for polar vein reconstruction. This surgery was carried out in the last century, and this patient could survive more than 5 years. 5 years and 3 months, this patient was died. Next case is another advanced hydrocholangiocarcinoma. The right hepatic duct was separated, anterior and posterior. We put the 2 PDBD for anterior and posterior. The resection line could be designed here, proximally to the confluence of the 8 and 5. For the right posterior sectional duct, the section line can be designed distally to the confluence of segment 6 and 7. And 3D angiography can be obtained in this century. Here you see a complete obstruction of the left polar vein, and the cancer invasion along the right hepatic artery. And the middle hepatic artery is also involved. However, left hepatic artery is intact. So from this information, I designed a hepatic artery reconstruction using left hepatic artery. Here to here. In this case, end-to-end anastomosis of the portal vein and end-to-end anastomosis of the left hepatic artery and the right hepatic anterior and the posterior hepatic artery could be carried out. As you can see here, we asked plastic surgeons to perform the microsurgical hepatic artery reconstruction. This case is a more advanced case. Here you see only right posterior segment duct could be demonstrated through PDBD through the segment 6 duct, and the caudate branch could be demonstrated. Another PDBD catheter, in this case, tip of the catheter was induced up to the segment 7, and the resection margin can be designed at the confluence of 6 and 7. 3D angiography clearly demonstrates marked cancer invasion of the right hepatic artery. And left is okay. Looking at the portogram, left and the right anterior portal vein is obstructed. From these findings, left hepatic trisectionectomy is indicated. Here you see a local cancer invasion of the both hepatic artery and the portal vein. And left hepatic trisectionectomy was carried out. And here you see end-to-end anastomosis between proper hepatic artery and the right posterior hepatic artery. And the portal vein reconstruction, iliac vein graft was used here. Next, I will show you a more difficult case of portal vein reconstruction in left hemihepatectomy. This is this limit of the portal vein reconstruction in left hemihepatectomy. I used vein graft, and I used a very, very special meticulous technique for portal vein reconstruction. I will show you. Anyway, the right anterior and right posterior and the left were separated into multiple units, and the big tumor at the iris. And here, this is very important findings. Diffuse cancer progress was observed on the cranial side of the portal bifurcation. And the ventral branch of segment 6, here, bifurcation is here, on the involved side, opposite side of the involvement. And the right hepatic artery is involved, but left is okay. For this case, local invasion is observed. And after liver dissection around the main portal fissure, local cancer invasion was observed after dividing the right interhepatic bile duct. Anterior and the posterior duct was divided. Even after biliary duct dissection, here you see a local cancer invasion on the cranial side of the portal bifurcation. Then I used a meticulous technique to resect the portal vein obliquely. And after dissecting the portal vein obliquely, and I used portal venoplasty technique to make this anastomotic site here, round orifice I made of the longitudinal to unite the longitudinal dissection, and we go to form one loop of the distal end of the anastomosis. And firstly, here you see distal end-to-end anastomosis between the graft and plastic change here. After distal anastomosis, proximal anastomosis was carried out. And here you see portal vein reconstruction was carried out. And finally, left hepatic artery was used to reconstruct right hepatic artery. Here you see distal portal vein anastomosis was very much difficult to perform. And the time is very short now. Only one. Yes, I will show you briefly the last case. This case is this patient had he had a second chance to receive the higher contribution. He underwent the left lateral sectionectomy for intrahepatic cholangiocarcinoma. And 3 years later, he was referred to us. And we performed the right portal vein embolization. I will show you. Right anterior posterior duct are separated here. And segment 7 is separated. So major part of the tumor is on the right side. After left lateral sectionectomy. So on the left side, only segment 4 is remaining. This is a dissection line of the left lateral sectionectomy 3 years ago. And here you see the hepatic complex here. According to this picture, I decided right hepatectomy and only left medial section could be preserved like this. Major part of the tumor located in the right side, and the limited progress cancer was defined here near the confluence of segment 4. However, the right hepatic artery is involved here, and the left medial branch of the hepatic artery is also involved. Very difficult case. And the ICG K value gradually improved after right portal vein embolization. And KICG level was 0.044, borderline. But looking at the segmental biliary excretion function, we separately corrected bile. And the biliary excretion rate from each segment duct, we counted the ratio of the biliary excretion from each duct. So segment 4 ducts, about 70% of biliary excretion was confirmed from the segment 4. So maybe this surgery may be the safe. Surgery was very, very difficult because of the marked adhesion of the left lateral sectionectomy 3 years ago. However, important pedicle could be isolated and taped. And here is the main tumor. And the segment 4 branch of hepatic artery, segment 4 duct, and the umbilical portion of the left portal vein, and the right hepatic artery could be isolated. Here you see a main portal vein tumor located here. And here I decided to divide the right hepatic artery and divide the medial branch here. Here, A4, and the bile duct here, B4, and the right hepatic artery here. After dividing the right portal vein at the hepatic portal bifurcation, right liver could be removed. And here you see, because of the very close division line of the right portal vein, after remove the liver, I decided to dissect and reconstruct the portal bifurcation, and end-to-end anastomosis was carried out here. After that, I asked the plastic surgeon to reconstruct the segment of branch of the hepatic artery like this. They prefer to use left radial artery for reconstruct the hepatic artery. And as you can hear, in this case, radial artery graft was put between the left medial and proper hepatic artery like this. Here you see radial arterial graft here, and the orifice of the segment of duct is here, and the portal vein anastomosis is here. This patient could survive more than 4 years after surgery. Looking at the survival curves for patients with simultaneous resection of the portal vein and the hepatic artery, we reported in Arab surgery 10 years ago. Look at here, mobility rate of the 54%, and the mortality rate of 2.0%. And here you see, with simultaneous resection is here, and other procedure is here. Anyway, the considerable good post-operative survival could be obtained by, here you see, R0 and M0 of the simultaneous resection. And here, R1 and R2 or M1 is here, and R resected. Anyway, looking at these survival curves, combined simultaneous portal vein and hepatic arterial resection is good than we expected. This is a short summary of the last issue. Preoperative surgical planning for locally advanced hydropanchicoma should be derived from thorough investigation into anatomical correlation between important biliary ducts and surrounding vascular structure. And anatomical microsurgical techniques have expanded surgery for locally advanced hydropanchicoma and prolonged survival. Now I will summarize my talk here. How to diagnose a resectability. We should be very careful to diagnose a local extension tumor. And anatomical location is very important. And how to manage the perioperative risk of the patient. And we should be very careful not to overlook the segmental cholangitis. We should be treated urgently by selective introduction of biliary drainage catheter. And after improving the surgical techniques with microsurgical techniques, we could expand surgical indication for locally advanced hydropanchicoma. Thank you very much for your kind attention.
Thank you very much, Professor Nimara. Because we're running out of time and I think we are full of knowledges, I think we will skip the case discussion to tomorrow morning. And so Dr. Anna would like to present the case. Okay. So we will continue the case discussion for about 10 minutes, and Dr. Anna will be presenting.
Sorry, I think professor discussion is more important than our discussion in the next session. Okay, just briefly the case. And I showed this case for Professor Nimara already last night. So I have briefly the case is a female 61 years old. She presents with my jaundice and have my elevation of total bilirubin. And just is her CT scan. It's a hyalocholangiocarcinoma. And have a bifurcation of a portal vein and narrowing of a left portal vein and the right hepatic artery is crossed over the hepatic hilum. Because we have many questions, but I think the most important question is type of resection, because I think resectable is okay, resectable for Professor Nimara, that we have seen in the last lecture. So for this case, what should the type of resection you prefer?
Because of the hepatic arterial invasion, only right hepatic artery is involved, and the left hepatic artery is intact. We can say, yeah, I see the left hepatic artery not involved, and the left portal vein is involved. Anyway, the right side is predominantly involved. The right hepatic artery is markedly involved. Therefore, left hepatectomy can be carried out if you like to reconstruct the hepatic artery. But right-sided dissection is more easy because of the intact left hepatic artery. And looking up this CT, left hepatic arterial dissection and reconstruction can be carried out. Therefore, I like to recommend right-sided or right hepatectomy, coded lobectomy, and combine the portal vein dissection and reconstruction can be done.
And did you concern about a future liver remnant of a lateral segment?
From these findings, how to resect and reconstruct left hepatic duct is very difficult to say. So I need conjunctival
Okay.
To define the dissection line.
And this case, we perform a PTBD on August 2016. And it's a PTBD to the left, and it's a right hepatic duct. And we can pass the tube into the bile duct, it's a gallbladder.
Any more questions on?
I take just one picture, sorry.
I can have to tell you the conference of segment 4. Where is the conference of segment 4? The conference is involved?
Yeah.
Involved here?
I think that is maybe a segment 4.
And how about another one? About? No. That's,
Is,
yeah.
Oh.
Is this 4?
Maybe 4B or 4A. You mean you want to preserve some of segment 4?
Yeah. Very carefully to demonstrate lateral section line. If the segment 4 is involved, the right hepatic trisectionectomy is indicated. We can get enough surgical margin in the case of right trisectionectomy.
Yes. And for the CT scan, do you think the left lateral segment is enough for future liver remnant?
How about the volumetric study?
Sorry, no measurement.
I see.
Maybe 30%, roughly estimation. Not more than 30%, I think. And for this case, you need a portal vein embolization.
Possible right tri-segment portal vein embolization.
Yes. Okay, and for this case, we perform a right portal vein embolization. Yeah. And 1 month later, we perform again PT cholangiography for measure the extension of the tumor to the left side. And then this CT scan after compared to the after right PVE. Yes, and a little bit enlarged of the lateral segment. Yeah. Any discussion? And then we perform a right dissection with highlight and portal vein resection and reconstruction. These are lateral segment, and these are portal vein resection and reconstruction. The pathology is R0 resection and also non-negative. This pathological report. Margin is free, and also a node is negative. For this case, we follow the patient now is 3 years, more than 3 years. This CT scan before operation and after operation. The portal vein still patent. And lateral segment is enlarged. Any comment? Professor have any comment for this case?
postoperatively, can you show the segment 3 branch of the portal vein, which is a segment 3 branch? This is segment 2 branch. This is 2. This 3. 2 or 3.
3.
Which is 3? No, which is
3.
2?
Yes. This is 3 and
this is the hepatic vein.
This is 2.
This is 2, and which is segment 3?
Yes, this is 3, I think.
Is it 2? Let me see the CT after portal vein embolization. Preoperative images. This is the
left portal vein.
Next, let me see the CT.
CT scan.
After portal vein embolization.
The picture is not clear.
Just one minute. Back. Yes. I'm concerned about the possible injury of the segment 3 branch.
Maybe embolization of the segment 4. Injury. Oh, I see.
Maybe you puncture the segment 3 branch.
Yeah.
To introduce a catheter to the right.
Yeah.
So I'm concerned about the possible injury of segment 3 branch. When we use the contralateral approach of portal vein embolization, we must be very, very careful. So we prefer to use the ipsilateral approach for portal vein embolization.
Yes.
This main part of this program is segment 2. So we are always concerned about the possible injury of the portal vein during portal vein embolization.
So, any questions from the audience? Thank you, Professor.
Thank you very much, Dr. Arnold. I think we come to an end of this session, and I'm going to say we are very fortunate to have Professor Yuji Nimara to attend and have a talk in our annual meeting. And he still be here with us until tomorrow morning. We have a special session. It's an early bird session in Meet the Legend at 7 o'clock. And we will give you a map for meeting him in the morning. And that will be the case presentation. You can come to discuss freely. It's a round table. It's not sitting like this. Okay. Thank you, Professor Yuji Nimara again. Would you please give a big hand? จะเบรกกันนะครับแล้วกลับเข้ามาประมาณ3:40 นะครับเรายังมีเซสชั่นที่น่าสนใจนะครับ panel discussion